tells you exactly where you can go to get those, and that should be, they're showing it right now. Those are the image references that I would recommend.
Yeah, and I'll make sure to send those out to everyone so that you have those. Question came across: does the structure software have the option for base structures from a particular source other than the users? The primary or the gold set or whatever you want to call it can be from anywhere. That can be created by just about anyone. That could be your best dosimetrist. It could be a doctor. We're working with the group up in London. They've got a method for actually creating a consensus contour. So there's some really neat stuff out there for creating that gold. Question came across: if you do not have the ability to give contrast and the MRI is done on a concave table, which we use for fusion, what is your suggestion?
Look for the scalene muscles, because I don't think with the MRI in a different location, in a different anatomic setup, I don't think the MRI is really truly going to be helpful to you, and I think you're going to just have to live with what you've got off of your CT and hope that you've got a good enough quality CT to see the anterior scalene muscle. You can almost always see the anterior scalene muscle and just contour beneath it. But if the MRI scan was performed in a different position than your planning CT, it's probably not going to be very helpful to you.
Okay. Anything else? I don't see any others. All right. Well, Dr. Wheeler, first of all, I just want to thank you. I know that you stepped in at the last minute here to help us out, and I thought you did and gave an excellent talk, which I think a lot of people are going to be able to take a lot of great stuff away from. And I really, really appreciate you taking the time to help us out.
Thank you very much.
All right. I'm going to pass it over to Ben now, and he will be talking about this actual contouring challenge and our results. Do you see your talk up there? Here, I'll get it up here. You see it there? Click on the down arrow on the right-hand side there. See it?
Okay, great. I will make this quick. I know, really appreciate that everyone's given so much time today. There are hundreds of attendees to this presentation, and so I will get done in 10 minutes or less, and we'll get to the moment everyone's been waiting for, and that are the results. I want to let you know, if you have any trouble hearing me, please send a chat to the host, and he will tell me to yell a little louder or move where I'm sitting in relation to the phone. Okay. Some of this I'll move through quickly because it's been covered very, very well by previous speakers. But really, the genesis of all this is all about quality, and quality is a word that really carries a lot of weight if you study quality in manufacturing, or the fact that every time you step on an airplane, there's been many millennium of man-hours spent on quality, and it should be the same for healthcare as well, obviously. The genesis of this, as Greg mentioned, was really the plan challenge, and I want to bring up Vicki again. She's a good friend of mine, and I remember the first plan challenge she did was several years ago, and I remember having the conversation with her that said, well, the plan results you see, a lot of the variation is going to be due to how they draw the organs, and some of the variation is going to be due to their different planning techniques. And if we were really going to do a good experiment, we should split out the contouring from the planning, and really that discussion. Whenever we do a contouring challenge, I always think of Vicki, because this was really where the idea for the contouring challenge was born, in that we are studying only the contouring variation. So why a contouring challenge? Really, in general, we want to raise awareness, first of all. This is a great way to improve quality in any clinic, in any city, in any part of the world. That is, if we contour better, quality will be better by definition. It affects everything, contouring. I'll use an example of, I'll use a topical example. We're here in Wisconsin, and it's been snowing a lot, and so I could go out and spend several $1,000s on the best snowboard equipment in the book. That doesn't guarantee that I get down the hill safely or I have a good time. That's going to depend on my skill and my practice level. So whatever equipment you have, a lot of time in radiation therapy, we think the quality that we can serve is based on the equipment we have, And I think it's much more based on the quality of the actual clinicians. The equipment is secondary. Now, the main difference in my metaphor there is if I have a big accident on the snowboard, it's pretty obvious because I either cause a cloud of snow or I leave on a stretcher. Radiation therapy is different. It's invisible. And like Dr. Wheeler reminded us all, some of the side effects from a mistake that could be based on contouring may not manifest for months to years. So we have to keep that in mind, that when we make a mistake or when we don't do things as well as we could, it's invisible and we don't really get audited on that. And so what we've been talking about here is all about quality. What can we do now to make very cost-effective measures to improve radiation therapy? So again, contouring really steers everything, and Neil covered this well at the beginning. It doesn't matter what equipment we have, what planning system we use, what imaging equipment we have. If we're not drawing the contours correctly, you can imagine all the things that can be affected by that. So I'm going to go very briefly over the experimental design and the methods we used for Contouring Challenge 2.0, and then we will get to the announcement of the winners. All right, the experimental design, we wanted to focus, again, just on the contouring. So we sent a common CT image set and made it downloadable on a certain day. There was a fixed set of regions of interest, or ROIs, that we requested people to contour. And then what we did was we had them upload their resulting DICOM RT structure set, and that's what we used to feed the measurement system. So the measurement was strictly quantitative. There's no objective or no subjective conclusions made here. We compared it versus the gold ROIs. The specific study for Contouring Challenge 2 were 316 CT slices at 1.25 millimeter slice spacing. And the regions of interest we requested were the spinal cord, brainstem, larynx, parotid, submandibular, and the brachial plexus. The CT data set was not only downloaded on that certain day, but it was also given to the expert panel to create the gold ROIs. So it was reviewed by several sources. On that specific day, we did want to make it somewhat time limited. We didn't want to give people a week to go study their anatomy books and create their contours. So we accepted any structures that were returned within half a day on the day of the contest. Now, very interesting thing here. We have hundreds of people who are interested in asking very good questions about contouring. We had only dozens who registered to do this. I want to encourage, as we go forward in the future, I want to encourage anyone to participate. It's completely anonymous. Whether you do great and win or whether your scores aren't so great, no one will ever know. You'll only know the winners. So really, you're part of a science experiment here, and the science is important for us to learn areas of improvement. The structure metric we used allowed for a 1 millimeter tolerance, so if any voxel was missing or extra within 1 millimeter, there was no charge at all. And then we put a not-so-penalizing slope on this, where you got penalized half a voxel for every millimeter outside of the forgiveness region. This is what it looks like. Now, I'd like to point out here, Dr. Wheeler mentioned something very important. When you're talking about critical structures, sometimes it's okay to contour too much, but never okay to contour too little, especially when it's a nervous system type organ. So you can create an asymmetric penalty function where for extra voxels, if you contour a little too much, you can penalize those not at all or a lot less than missing voxels. But in this case, we did a pure symmetric because we just wanted to see what's the variation. An example here then, if you had a voxel that was 1 millimeter away, there's no penalty. Half a millimeter, or 2 millimeters away, you get a penalty of a half. 3 millimeters away, you see how this goes, and it was linear beyond the forgiveness region. Here are some of the simple results then of what we saw, and I'll try to highlight some of the differences. These are presented from the top to the bottom, from least variable to most variable. Spinal cord was least variable. This is showing only the total volume, so it has nothing to do with whether it was in the right place or not. It's whether they contoured the same volume. I'll point out some things here. So for the least variable was the spinal cord. The volume of the gold versus the mean. You can see here already we have a little bit of a concern where the gold was on average about 20% larger, and like I said, it's never a good thing to contour too little of a critical structure. Brainstem, we see it was closer in mean. but we did